Daniel is going to present, and we're going to talk about the FFR trial.
Just one second. Hello, everyone. Good morning. My name is Daniel Bandeira. I'm going to present today's journal club. Just before I start, I'd like to thank you all for being here. This month is my last month as a fellow here in the US, so I'll be heading back to Brazil. Daniel brought me here for 2 years, and then it went by so fast. It's been already like the last month. I made great friends here, and I had great experiences. I'm going to bring back home great memories. So thank you all. Today, I'm going to present the FFR Europe that was presented at TCT last year, which is QFR versus FFR for coronary revascularization guidance, a multi-center randomized non-inferiority trial, which was published simultaneously at the Lancet. But before I do that, I want to give you a brief, not passing my slide here. Okay, I want to give you a brief background. We all know that the pressure indexes such as FFR and IFR, they are recommended by the guidelines to assess intermediate lesions. It's recommended as class 1A by both the European and American guidelines. But despite of that, as you can see in this map here, the worldwide adoption of physiology remains pretty low. Most of the map is red, as you can see here. Of course, the US and Europe, Japan are green, but it's not that good. It's above 10%, but it's below 20%, which is still very low. As you can see in this trend from Europe from 3 years ago, from 2007 to 2018, even after the great seminal trials such as FAME1 and FAME2 and the IFR Sweetheart and the Fine Flare, it's still below 10%, the overall usage. And data from the US, from the VA, shows that also the use in all comers is still below 20%. It jumped from 14.8% in 2009 to 18.7% in 2017. As you can see in the right, it's basically the same data. And as you can see, although we have more outliers from that period to now, to 2017 actually, we have an increase of outliers. Maybe the even VA is this little dot here, 100%. Where's Dr. Fall? But the mean, which is this orange line here, remains pretty much the same. So there's no change. And the reasons for that are many. People may say that it's too costly, which I think is not the reason in the US. Lack of expertise, the lack of availability of the technology, the perceived risk, although we know already it's pretty safe, but people may still think that it's sometimes risky to use, or the increase in procedure time. Or perhaps have other reasons, such as lack of humility. Some people may think that they just know too much. They think that the angiography alone is all they need, or they're just lazy. Some people are just lazy. They want to do, less work and go home. But the thing is, because all of that, we needed some approaches, new approaches to increase the use of physiology in the cath lab. So here comes the concept of imaging-derived FFR, which is functional imaging. Of course, today's topic is angiography-based FFR, but we cannot forget that we also have in the cath lab the OCT-based FFR and the ultrasound-based FFR. They all follow the same steps, basically, which is acquiring imaging. That can be angiography, that can be, of course, from IVUS or OCT. Segment the lumen, nowadays is basically done through the use of AI, so it's all automated. With the lumen segmented, we get a vessel geometry, which we can use the 3D model or the 2D model nowadays. We define the vascular references and the tapering of the vessel that can be done through linear interpolation or adjusted by side branches, which is more, in line what really happens. And then come the magic of these methods, which is the simulation of the FFR throughout the vessel. That can be done through computational fluid dynamics, which is more computationally intensive, or supposedly is more accurate, takes more time. Or we can just use simplified fluid dynamics equations, which have a lot of assumptions, but are faster, and has been proven to have similar numbers that are output by the CFD. And then we get the final output, which is basically a color-coded map of the vessel with the reddish colors being more, meaning a lower FFR throughout the vessel. This is a compiled of all the studies used to validate these technologies. As we can see here in orange is the QFR, today's topic. And as you can see, the first line, the 8% threshold for accuracy, and the other line to the right is the 90%. Most of these studies are well above 80% accuracy, and some of them are even above 90%, so it's pretty good. But the thing is, people don't care about the overall accuracy. What they care about is outcomes, and that's why they designed the biggest trial so far with this technology, which was the FFR3 China, with stable or unstable angina patients with planned PCI and intermediate stenosis in vessels bigger than 2.5. These were the exclusion criteria. And they randomized almost 4,000 patients to either a QFR guided strategy or an angio guided strategy. And the primary endpoint was MACE, firstly at 12 months, but they have already published the 2 years follow-up. And as you can see here, the QFR was better than the angiography alone, 85% versus 12.5% at 2 years, has a ratio of 0.66. And in landmark analysis, the benefit seen in the first year was also seen in the second year, so it was sustained. Because of basically that study, the S guideline last year, they endorsed to assess intermediate stenosis, the QFR with class 1B. They gave the same level of recommendation as FFR and FFR for patients with multivessel disease, which is 1A. And they also gave 1C to assess CAD in patients with HF. And that's the scope of the FFR3 Europe. The main objective was to determine whether a QFR-based strategy is non-inferior not to angiography, but to the gold standard, which is the FFR, to guide coronary revascularization. It was a multi-center, randomized, open label and non-inferiority trial across 34 centers in 11 countries in Europe. These are the inclusion criteria, which is basically stable disease, intermediate stenosis in vessels bigger than 2.5. And these are the exclusion criteria. I just want to highlight that, of course, the patients had to be suitable to do both QFR and FFR. They couldn't have a life expectancy lesser than 1 year, CTOs, left main disease, or bypass grafts, which can, of course, impair the assessment of FFR. So the primary endpoint of this study was also at the FFR3 China, the MACE, which was a composite of all-cause death, any myocardial infarction, or any unplanned revascularization at 12 months. And the secondary endpoints, they used the TVF, which was a composite of cardiac death, target vessel MI, or ischemia-driven target vessel revascularization. They assess all the individual endpoints at 30 days, 1 year, and they're also set to assess them at 2 years. And procedural endpoints, which are the feasibility of QFR and FFR, the procedure time, contrast volume, fluoroscopy time, number of stents, and lesions interrogated. For the sample size calculation, they basically use the numbers from IFRs with the heart and defined flare, which saw a MACE rate similar in both groups of 6.7, and they also defined a non-inferiority margin of 2.4% of absolute risk difference favoring FFR. And to have 85% power with an alpha of 5%, they calculated a sample size of almost 1,500 patients, but of course, to account for uncertainties such as drop of follow-up, lower MACE rate than expected, they decided to enroll 2,000 patients. They did all the analysis in an intention to treat fashion, but they also did a per-protocol just a sensitivity analysis. They used the Kaplan-Meier estimates as a time to event analysis and the Cox proportional hazard models. And the hypothesis was that the upper bound of a one-sided 95% confidence interval or two-sided 9% confidence interval would exclude this difference in favor of the FFR. They screened 2,369 patients. At the end, only 2,000 were enrolled, so 300 were excluded for many reasons. And they were randomized 1-to-1, stratified also by LAD disease and diabetes. 1,008 patients for the QFR strategy and 992 to angiography guided strategy. Because of failed strategy or crossover of the patients, 33 were excluded from this analysis here, and 37 from the angiography guided strategy. And in total, 975 patients were in the group of the QFR guided evaluation, and 9055 to the angio guided evaluation, but all of them were included in the patient to treat analysis. Does anyone have any comment about the design of the study so far? Can I proceed to the results? Okay.
Hey, Daniel, this is Steve. Do you mean when you say angio-guided evaluation, you mean FFR?
No, the angio guided would be only a visual estimation of the stenosis. No physiology methods used. There was no FFR in this study. Sorry.
Okay.
FFR. There was FFR in this one. Sorry. Yeah. My mistake.
Thank you.
Sorry. So, yeah, I'm sorry.
Can I make one comment? Can I say one thing? So the non-inferiority margin that they selected, just so that we're aware of this before seeing the results, is that an absolute difference of 3.4% when you expect your event rate to be 6.7% is huge, more than what would be clinically relevant. So they set the trial up to succeed. They wanted it to be a positive trial meeting non-inferiority with that kind of margin.
Yeah, they just use this number because it was the same number. They even say that in the methods that was used in the IFRs really hard, but I agree with you that there's a huge difference, definitely. So this is the table 1 of the study. I'm just highlighting what I thought it was important to show. So the mean age of both groups was about 65 years old. Most of the patients were male, 3/4. 1/4 was diabetes patients. 50% of them have had PCI before. Most of the patients had a normal kidney function. Most of the patients were asymptomatic or oligosymptomatic. As you can see here, almost 90% of the patients had angina class 1 or 2, or had no symptoms at all. And almost all the patients had NIHA class 1 or 2 at the baseline. 2/3 of the cases were stable patients, and the remaining were non-stable patients but already stabilized, which was 48 hours after the event. Most of the patients had 1 or 2 vessel disease. Only 10% had 3 vessel disease. And most of them were from low to intermediate complexity, with 65% of the patients having a syntax score below 11. About the procedures, we had a high rate of success, and we can discuss, if it's what we see in real life, but 96% of the patients had a successful QFR or FFR. And when you go to the lesion level analysis, also 97% of the lesions that were interrogated were also successful. As you can see here, 50% of the patients had disease in the LAD, about 25% in the right coronary, and the remaining in the circumflex. The median QFR was 0.81, which was significantly different from the FFR, which was 0.84. And because of the lower QFR, of course, the QFR deemed more lesions to be significant. And it was also significant. And therefore, they also treated more lesions. This is a distribution of QFR and FFR. Of course, they concentrate more on the distribution around the cutoff, which is 0.8. But the left tail of the QFR is much bigger, as you can see. And the supplemental table here shows us that the proportion of significant lesions across all the vessels was, of course, higher in all the categories of QFR. But what gets our attention is that in the circumflex territory, the disproportion was much, much higher. While in all the vessels, it was about 5% difference. In the circumflex territory, it was about 15% difference. It was much higher. Also, of course, it was more stents implanted in the QFR group. And the total fluoroscopy time was also higher in the FFR group, of course, because you're doing a procedure more. Do you have any comments about this? What do you think, Mike? Was this population here representative of our practice? Does anyone have any comment? No? So going to the results.
Sorry, Dan, could you repeat what you said about the circumflex? I missed it. There was a greater discrepancy between QFR and FFR in the circumflex territory?
Yeah, exactly. So this is a table that shows the proportion of vessels interrogated, significant versus the interrogated number of vessels. And as you can see here, the proportion of all the vessels is bigger in QFR group. As you can see in the LED, for example, is 56% versus 51%. There is, of course, a discrepancy because there was more lesions interrogated in the QFR group that were positive. But in the circumflex territory, this proportion is much higher. So 36% versus 15%. The circumflex in the marginals, in the intermediate branches. All of the three are much higher discrepancy.
So something that's not clear to me in the trial, did everybody in the FFR arm get an FFR, or was it first an angiographic decision? Like, okay,
No.
I think this was intermediate, so I'm going to do an FFR, but maybe it's someone else thinks it's not intermediate.
That was my mistake at the beginning. Everyone got FFR evaluated. We had a small crossover below 40 patients, but most of the patients had FFR.
But the angiographic evaluation was the screening for both arms, right? The physician had to find an intermediate lesion by angio, and that would be an eligible patient to be randomized.
Okay. All right. So basically, I'm asking everybody in the FFR arm got an FFR.
Yeah.
In all three vessels.
If they had disease, of course, in the three vessels.
Okay.
Sam, only the functionally significant or the intermediate lesions were interrogated. So if it had like a 50% circumflex, then that would be a patient enrolled for the circumflex and they'd get FFR.
Okay, so they would ignore. It's not like they were picking up stuff with the QFR that.
No, and again, QFR, like different from FFR angio or CathWorks, is that it's vessel specific. So you do your QFR analysis per vessel. So it's not doing all three vessels.
Thank you.
Only 10% of the patients had three vessel disease and did, of course, QFR in the three vessels, but you only did if you had disease in the vessel by angiographic evaluation. Right? So this is the primary endpoint result, which was 4.2% of events in the FFR guided group versus 6.7% the QFR guided group, which gave us the hazard ratio of 1.63, the confidence interval from 1.11 to 2.41. The absolute difference mean was 2.5%, but the confidence interval upper bound was 4.2%, which was well above the pre-specified margin of 3.4%. So QFR was not non-inferior to FFR in this scenario. We also have here the graphs for all the individual components of the primary endpoint. As you can see, there was no difference in death or revascularization, and it was mainly driven by an increase of myocardial infarction. And this is the TVF at 12 months with also no significant difference. Although, of course, numerically it was higher in the QFR group. These are the tables.
Double check, what was the definition of myocardial infarction for this study?
Any myocardial infarction.
So even a little troponin rise after PCI. would be-
Yeah, but they
Actually,
also
that
did
was-
this analysis.
That was driven by peri-procedure.
But there's a challenge with randomization in this study that there were numerically more STEMIs, right, in the QFR group.
This was numerically more. No, not numerically more. There was more myocardial infarction in follow-up. There was spontaneous infarction more. I'm gonna show you the table just after this one. It was an increase in per-procedural too, but it was not significant. And when they isolated only the spontaneous, it was also higher. I'm gonna show in the next tables. So this is a composite, 67 events versus 41, as I just showed in the graph. And it was driven by any myocardial infarction. That was no difference in the other individual outcomes. When you go to the secondary clinical endpoint that was in the supplement, when they do the primary endpoints without per procedure, it was also significant in favor of the FFR. And when they assess only spontaneous MI, it was also significant, the 2-year follow-up. As you can see, it has a ratio of 2.06. Okay. And they also did a per-protocol analysis, a sensitivity analysis, as I said before. And in the per-protocol analysis, it was also significant in favor of FFR. This is a subgroup analysis. The benefit was of course, the benefit in favor of FFR was consistent across all the subgroups except tandem lesions. So the presence of tandem lesions, and the authors hypothesized that because FFR has some trouble in assessing, sequential lesions, maybe that favored QFR. But nevertheless, it was consistent in all subgroups. QFR was worse. So this is a table of the primary and secondary endpoints at 30 days. There was no difference. As you can see, any myocardial infarction, which would account basically for all the peri-procedure and early events, was not that different. So the conclusion of the trial was that, of course, the QFR strategy did not meet non-inferiority compared to the FFR guided strategy in the evaluation of the intermediate stenosis. So FFR remains the preferred standard for functional lesion assessment, but QFR may still have a hold where FFR is not feasible. I'll open for discussion. I'll have some questions to make to the group, but just like Michael always like to do, we had some commentaries in the Twitter. David Capodano said, ouch, QFR was worse, more stents, more infarction. Who will give me back the hours I spent obtaining the certification? Other people said were more aggressive, saying that shortcuts don't work. This is even how I feel about IFR versus FFR. So IFR also is not that good, apparently. And some people were more moderate, saying that it's not good news, but we may still find a role for QFR as a, screening tool or when FFR is not available. So I have some questions for the group, but if anyone wants to hold the discussion, it would also be good.
So I'm a little confused. So there were more interventions in the QFR group,
Correct.
and but there were still even more. So even if you excluded peri-procedural MI, there were still more later spontaneous MIs in the QFR group.
Yes.
Yeah, Sam, this is a great point. And Daniel, can you go back to your pre-randomization, to your baseline demographics? I just want to look at the study population closely, because when I first looked at this, the populations were a little bit unbalanced.
I have 3 pages on 3 slides, so let me know if you want me to pass this up.
Do you have the distribution of how many presented with ACS for their before randomization?
Yes, here, clinical indications. And the secondary evaluation, understand that it's 48 hours after the primary event.
Cat 80's tongue. Hi, guys, this is Natalia. I'm a former fellow. I just wanted to bring to your attention the CCS class here. So this I thought was surprising, but actually, I have a registry going on of FFR procedures, and I get the exact same thing. So these are patients who have little or no symptoms. So really, it begs the question of what exactly are we trying to do here?
Yeah, I agree with you that we have no
So
job.
the one part of asymptomatic patients might be the ones that had an MI and are evaluating additional lesions that are non-covered lesions. That's the assumption, right? But I agree. So we're discussing here about peri-procedural MIs, spontaneous MI, and mortality, FFR, and physiology in general. It doesn't tackle that, right? So we're trying to identify ischemia-producing lesions to hopefully improve patient symptoms. If you were dealing with a very low symptomatic population, it makes no point. I totally agree with you.
And I just want to show one more data that was published recently in neurointervention. That was a sub-study of the FAVOR 3 Europe, regarding this question of more procedures, because the main point is because the QFR group had more procedures, randomized, and that what was drove the main endpoint. But actually, in this sub-study here, they only evaluated the deferred population. So they assessed the patients that had a complete study deferral, so they had no PCI at all, or that they have at least one lesion deferred. And in the complete study deferred, as you can see, the QFR group deferred 433 patients, while they deferred more, and the endpoint was still higher in the QFR group. It was significant because this group, in this case here, was because of an increase of unplanned revascularizations, but the numerically the MIs were also big. So apparently, it's not as safe as FFR in different lesions when you use QFR. It's not the paper for today, but just brought the graph here so the group can see. And I have some questions.
Daniel, sorry, and this is MI or this is unplanned revascularization? What is the
The composite endpoint was MACE, but when you go to the individual endpoints, numerically, all the endpoints were greater, but the only one that achieved significance was unplanned revascularizations in this paper here, but it's a sub-analysis with half the population per group, so.
Yeah, I hate the idea in a non-sham or non-blinded or unblinded trial. I hate this whole unplanned revascularization because once the operator and the patient knows they've got to, I don't know how to interpret this study.
Yeah, no, I share your concerns about that, and I think all this MI discussion is kind of confusing in interpreting the role of physiology in general, right? So if you look at the Kaplan-Meier curves, the curves separate very early on. This is mostly driven by peri-procedural events, and then it makes no sense that you indicate more PCIs with QFR, and then you say that the events that occur spontaneously over 1 year are driven by more MIs because you missed lesions. So what is QFR doing? Is identifying the wrong lesions. We're putting stents in wrong places and having more peri-procedural MIs and leaving the important lesions behind, and then you still have more spontaneous MI. It makes no sense, right? So.
Can I interject and say something there? So I actually think you might be onto something there with the comment that you just made. I've looked in detail at how QFR is validated and the diagnostic performances. They're reported as rather high in all the studies so far. But I've tried it personally, and I know this sounds funny, like maybe there's a me problem here. But yeah, the results are all over the place. I have FFR values. I run the QFR, and it's different every time. You can get like you can get a positive lesion, you can get a negative, you can make a lesion positive or negative. It's very operator dependent, unlike FFR, which is reproducible between operators. And there's a study to this effect. It's called QREP. It's only a 50 patient study, but they basically show that, you know, inter and intra observer variability is huge for QFR. And so, you know, I really think that is actually what's happening. It's misclassifying all kinds of lesions as either positive or negative.
Yeah, no, you're totally right. And so I've been doing QFR since the very first version, and it was horrible in the beginning, in the meaning that if you move one frame forward or backwards, your results change completely. So they improved the system significantly. It's much more reproducible now, but it's still, as you said, very operator dependent. And QFR has all angio-derived physiology, not only QFR specifically, but they have a tendency to overestimate vessel ischemia in general, by meaning that they assess each lesion individually. And that's why, so if you look at the histograms that Daniel showed carefully, you see some QFR values close to zero. We don't see an FFR value of 0.23 or 0.31, and that's very common for QFR. Right, so to get an FFR of 0.30 something, that's a CTO, right?
To zero.
So you see very low values with QFR, which if you have like serial lesions or very long lesions or tight lesions, QFR just adds them up. And in a way, you tend to get very low values with QFR, and that's why we have more overestimation of vessel ischemia. Regardless of the reclassification that we have. So that explains why we're indicating more stents with QFR. But what doesn't make sense to me is that we're treating more, and then we're still getting more events later on. So another comment about this validation. So all validations published have been driven or sponsored by the company that makes the software, which is One Bias. The second is that they look into an overall accuracy, which is one accuracy trying to estimate how QFR performs against FFR, and that's not a single cutoff issue. Accuracy is a continuum. You have a spectrum of accuracy. So the more stenotic the lesion, the more accurate you're going to be to detect a positive FFR lesion. The milder this the lesion is, the more accurate you are, that is, FFR is going to be negative. But if you are around the cutoff, the accuracy drops like significantly. It can go down to 50%. So there is a continuum of accuracies as well. And so this is a topic that we're studying on a meta-analysis of all those studies. And it's surprising that the accuracy can be very high if you're in this severe or non-severe spectrum of the disease, or it can be extremely low if you're in a range of QFR values around the cutoff. And the window of uncertainty is very large as well. It's not only around 80%, 0.8 FFR, it's really from 0.6 to 0.9 something. So there is a large window where your accuracy can be very low, and that explains these reclassification issues you're mentioning. Long answer.
Yeah, in line with that, Daniel, in the protocol, of course, all the operators have to have a certification where they do 30 cases before the study starts, and they had a feedback for each case. So if they do a case, they have feedback like immediately. Do you think that any more thing can be done, to reduce this problem of interoperator variability? What else can they do, or it's just a limitation of the technology?
I think it's a limitation of technology. To use QFR, you have to be certified. I had to do the same 30 cases back in the day. I spent hours doing that, and then you send to the company reviews them, give you comment, and then you get a certificate that you're a certified user for QFR. But at the end of the day, as Natalia said, you get into real cases, and there are limitations of angiography acquisition, there's overlapping, there's foreshortening, there are long lesions that you don't have two perfect angiographic views to see the whole vessel. So there is a lot of confusing factors in that. So in terms of the clinical trial, I think they did the best they could. So they certified users, they did additional training, they did next day feedback for every single angiography measured as they report. So I think they did the best they could, but there is a limitation of the technology, It's still very operator dependent.
Yeah,
Also,
you're absolutely right. I really like all the points that you brought up about the accuracy, around the cut point, like like for FFRs between 0.78 and 0.83 or 85, it really becomes inaccurate. And then the second thing you said, in the study that I referred you to, the QREP study, the one thing that predicted more inter-observer variability was poor quality of the angiogram. They scored angiograms in terms of like what you were mentioning, foreshortening, overlap, and so forth, like poor contrast flow, to see what things like if it could affect the QFR accuracy. And so they didn't really, in that study, they didn't show how it affects the correlation coefficient with FFR. So they didn't show how it affects accuracy. It was a small study, only 50 cases, but they do show that there's more inter and intra-observer variability if the angiogram is worse. So take good angiograms.
Can I add two more things to this? So the first is that physiology is not valid for severe lesions. And so to Daniel's point, like when you're getting these QFR values that are extremely low, those are probably lesions that shouldn't have been assessed with physiology. It should have been a clinical decision, especially in the setting of ACS, whether they should have been fixed or not. And then the second, Daniel, like how do you compare this to Favor 3 China, which now has 2 years outcomes data, which looks very different than this?
Well, I think so. These are different comparisons. So if you look at Favor 3 China, the QFR values were much lower than these ones. So 90% of the lesions were significant. So there is still, indicating stents on very doing physiology in very severe lesions. And what they showed was, as compared to just regular angiography, the operator eyeballing lesions and defining which one is significant, which one should be treated, QFR was better. So it's not as perfect as FFR, but if you don't have invasive FFR available, it's still better than just eyeballing lesions by angiography. So anything, if you think on the other, by another angle, if you get a population of mostly stable patients and you have a tool that indicates less stents, you should have less events, right? So, and when you look at the Favor 3 China Kaplan-Meier curves, the curves separate very early on again, so it's very procedure-wise, right? So you're indicating less stent with QFR and you have less events. So I would place QFR at the moment as an intermediate tool, better than only angiography, but worse than invasive physiology if you have available.
Yeah, I also think it's good as a binary, like a screening tool. So you basically can rule out lesions reliably to defer, but you shouldn't use it to rule in lesions to treat.
Yeah, and I have another comment about how we use physiology. So every single trial we see is just a vessel level evaluation, right? So you put the wire down or you do a QFR on a vessel level, and you report your QFR value or your FFR value per vessel. But often in practice, we see long lesions, tendon lesions, multiple lesions. Sometimes you're doing an LAD vessel, there is a left main lesion, which seems mild, but there is some resistance to flow as well. So if you think that QFR, although it overestimates lesions and it's highly unreproducible, but it gives you a map of where the most significant pressure drops would be, that could also orient which lesions should be treated to recover, normal flow and a normal FFR in the vessel. So it's more than just a vessel level value, but also a longitudinal vessel assessment that can help target the proper lesions. Sometimes you're doing an FFR in a vessel and then you're still eyeballing to find which lesion is the most significant you think that could be responsible for that low FFR. So QFR gives you an objective evidence of, a pullback curve to orient you where to treat the lesions. But we don't have this data yet, so.
Yeah. And I have another sort of radical application for QFR, which is I think maybe you should use QFR once you've decided to treat the lesion. So, but not to determine which part is the most severe, but whether you should treat it at all. Because even when we look at lesions and we say, oh, this should be treated, and a heart team decision is to treat something, I think we still end up potentially treating lesions that are not hemodynamically significant. Again, Samit said, if it's really severe, you shouldn't use physiology to assess this. But we need to consider this, that maybe we still end up doing too much PCI, and that we should. This is wrong for an interventionalist to say, that we should use maybe QFR to figure out when we are wrong, and we shouldn't really be revascularizing something that we really thought we should.
Can you guys comment on the deferral data that Daniel showed at the end of his presentation, where QFR graded out worse in the patients that were deferred?
I think Sam was very spot on his comment. It's an unblinded study, mostly driven by unplanned revascularizations. So it's hard to make sense of that data, no?
So this is the paper that was published in Euro Intervention. I just want to make sure that I didn't say anything wrong about the endpoint that Samuel asked about. This one here. Yeah, MACE was significantly lower. Yeah. All the individual endpoints were not different, but numerically, it had lower unplanned revascularization.
It's a double revascularization.
Yeah. But yeah, it was not significant.
Oh, okay. Let me rephrase. So I didn't mean for the intermediate lesions. I meant for the lesions that you think are severe and you should treat. And then you do a QFR and it's negative. You should maybe confirm those with FFR. Like maybe that's where QFR can help you to see where you really should have done an FFR instead of just going for treatment.
Does the group have any theories of why in the circumflex territory there was such discrepancy?
Well, because QFR is just a mathematical calculation. And QFR doesn't discriminate with the vessel territory, if it's a circ or an RCA. The only thing QFR does is it separates LAD left main from the rest. So it treats that circs as an RCA, as a diagonal branch, as a ELB. So it doesn't account for the myocardial mass, and usually circumflexes irrigates a lower territory mass. So that's why. So even FFR, if you're doing invasive physiology in the circ, usually you need more significant stenosis to get a positive FFR, right? There is less territory at risk. And QFR doesn't account for that. So that's.
Yeah, exactly. It does account what you said, like for the LAD. So maybe if, they introduced into the model a way to separate the LAD, the circ, and the RCA, maybe, the circ needs its own, just like the LAD, left main LAD has its own kind of calculation. Maybe the circ needs its own calculation and it is what we were talking about earlier. If you look at the circ, all of these lesions were classified as intermediate, yet only 15% of FFRs were positive. So you think that something is going to be significant, but it ends up not being because of the lower myocardial mass or whatever the other reason is. Or maybe it's like an infarct vessel and it's not going anywhere or something along those lines.